Yes, ladies and gentlemen, dear colleagues, welcome to Berlin in this historic building for a lesson from COVID-19 pandemic. We have a very international audience, and we also have very international and distinguished speakers tonight for several topics that relate, and we're going to try to relate the COVID-19 pandemic and our experiences that we had in the last almost 3 years regarding this to treatment of a disease that is similarly severe, sepsis, but is not as present yet in our mindsets, at least not for those who are not in contact with intensive care medicine. I would like to keep this short at the beginning and welcome our first guest and speaker, Professor Axel Pries, who is a professor of physiology and currently president of the World Health Summit, one of the leading international conferences on global health. Of course, most of us also know him from his many years serving as Dean of Charité, which he was also during the COVID-19 pandemic. So difficult times also for the research department of Charité, and he brings together his vast experience from physiology, science and health management, but also from a global health leadership perspective. Welcome, Professor Pries.
Thank you very much, Professor Horst, for the very kind introduction. I'm not a speaker. I'm only asked to give a greeting to you all, but I do that with a lot of enthusiasm because the disease and the lessons are very, very relevant. And the question is, did we really learn the lessons? You were referring to the time as a dean when COVID hit also the Charité, and I must say, in terms of the scientific community, the reaction to this threat was really positively overwhelming. As a dean, I found out that 90% of all researchers at Charité were actually virus experts, and one way or the other related to solving the problem. That's a joke, but it's really true that every discipline tried to find out what can we do to deal with the COVID crisis, like for instance psychology or things like that, where they were discussing how to deal with the enforced change in the lifestyle, which was very demanding, especially for young people. So very many disciplines worked together and contributed to dealing with the crisis. And I think it's true for COVID, but it's also true for sepsis, that you don't only need the hardcore medical approaches, you need a psychological, political, also economical approach to solve the crisis. And from the World Health Summit this year, one aspect which was very impressive was the question of trust. And I think that's another component. Working together in the Charité at the time of COVID was feasible because the researchers, and Professor Horst knows it because he was in the COVID research board from the very beginning, there was a certain level of trust established between the different researchers, and that led to a very good outcome. But with respect to the political level, I think we're still lacking trust, or we are suffering from a lack of trust. And the question is, what are the right answers? And I brought you here I'm not advertising here, but I brought you a very renowned journal, the Foreign Policy Journal. And on the title of this recent issue, they say, multilateralism is at a dead end, but powerful blocs are getting things done. And I'm not so sure I would sign that. Because if we are not able to create a multilateral defense against crises, both the COVID crisis, but also sepsis and many others, we will not be able to create a good health all over the world. And it's true that sometimes big blocs talking to each other bilaterally can be faster, because everyone knowing UN, WHO, large multinational organizations, even scientific societies, knows how much time it requires to get people from all different backgrounds to a common setting. But this time is well invested. We are people, and one of the strongest, let's say, achievements of mankind is the social brain, if you wish. If you look at the different parts of the brain, you know that the frontal part has developed strongest over the last developments towards humankind. The funny thing as a physiologist is that if you are asked what's exactly in here, there is no clear answer. And there is this very interesting case of a North American railway worker, and he was charged in compressing the explosives to get the ground with a metal rod. And at some unfortunate day, the explosive exploded when he was compressing it with the metal rod, and the metal rod went right through his front head. And he survived that. He lost one eye. He lost quite a bit of frontal brain, but he was discharged from the hospital without any deficiency. But his social life afterwards collapsed. He lost his job, he lost his family, wife, and he went homeless. And I think this frontal brain is meant to keep social groups together. The only problem is that the social groups the brain was designed for are small groups of people, tribes, something similar. We have to translate it to nations, to regions, to the whole world. And this is the most relevant lesson. Let's transform our frontal brain to solve the problems. How can we interact across borders, globally, disrespective all what is seemingly dividing us? We are all people, we are all humans, and we have to work together. Thank you very much.
Yes, thank you very much, Professor Priest, for this very surrounding introductory statement. I think in the discussion later, some of these aspects will come up again, especially on how to work together internationally and how to also work with underserved areas or resource-poor areas. I think that's going to be an important aspect today. I would like to welcome our next speaker internationally from Georgia. And Dr. Mariam Yashi is a Georgian politician and senior policymaker in global health. She serves as board member of UNITE, which is a parliamentarians network for global health. And she also is currently Deputy Minister of Health in Georgia and has been a member of the Georgian Parliament. Among several other political and health-related functions that are too broad to mention all of them right now, she also serves for underprivileged health groups in her functions. And most recently, she became designated CEO of the Global Sepsis Alliance. Welcome you here in Berlin, Dr. Yashi.
Professor Horst, thank you very much for your kind introduction. Professor Priest, Professor Reinhart, distinguished colleagues and special guests, Dr. Uzma Syed. I would like to make some of the key introductory points on the importance of the lessons learned from the latest pandemic and why it is important to draw the lessons not only on the overall COVID-19 experience, but how it has been related to the viral sepsis or the overall global burden of sepsis. Based on the latest dashboard of WHO, since the outbreak of the pandemic, officially there were 772 million COVID cases reported. That unfortunately resulted to almost 7 million deaths. And we have been the witness of the most devastating pandemic of our contemporary global health crisis, with the immense human suffering and economic disruption that brought together. At the same time, if we speak about the figures, based on the International Health Institute of Health Metrics and Evaluation, based on the latest global burden of disease estimates that is equally shared by WHO, Global Sepsis Alliance, and all key stakeholders in the area of sepsis, every year sepsis affects up to 50 million people, and every year we have at least 11 million deaths among children, women, and men. The latest estimates from the Institute of Health Metrics also has higher estimates of mortality, exceeding 13 million deaths every year. But this is the latest estimates that WHO also recognizes, and if you open the WHO official fact sheets, those statistics will be there, and also the Director General highlights the importance of those data. Sepsis is the cause of 1 in every 5 deaths globally, both from infectious disease causes as well as non-communicable diseases and injuries. And it has been a hidden global health threat that unfortunately is not yet fully recognized and adequately addressed in the global health dialogue and architecture. Till today, it receives disproportionately low political attention compared to the human and economic burden that sepsis brings to the global communities. Even more important is to highlight the interconnections and interrelations between the COVID-19 experience and the sepsis. And WHO, based on its latest 2022 estimates, reported that since the outbreak of the pandemic, we had almost 15 million excess deaths due to COVID-19. And substantial number of those 15 million excess deaths can be attributable to sepsis. The 2021 data from the study, the systemic review and meta-analysis completed by our colleagues and also co-authored by one of our esteemed colleagues, chair of the European Sepsis Alliance, estimated that COVID-19 related viral sepsis were reported in 78% of COVID patients admitted to the ICUs and 33% of adult patients admitted to general wards. COVID-19 is not yet perceived as viral sepsis. It has been underreported or reported primarily as the complication to the secondary bacterial infection that indicates to the need of awareness raising among clinicians, public health workers, and policymakers on the COVID-19 related sepsis. The second study, authored by Chapal and colleagues, highlighted that COVID-19 has changed the landscape of sepsis epidemiology. COVID-19 increased sepsis rates. There has been a growing consensus that severe COVID-19 is appropriate to label as sepsis, and the surveillance strategies need to be modified to fully capture and delineate the current burden of sepsis. Some of the other studies have reported striking similarities in clinical manifestations and the outcomes between the severe COVID-19 cases and sepsis. Acute manifestations and outcomes of severe COVID-19 were similar to sepsis caused by other pathogens reported by Prescott and colleagues in 2020. There has been a striking parallel between bacterial sepsis and COVID-19 phenotypes in terms of long-term sequelae, also reported by colleagues in 2022. And there is a study from our Turkish colleagues reporting that many COVID-19 patients meet diagnostic criteria for sepsis and respectively, the treatment approaches, the basic principles should be also similar. And we can continue in citing different articles and works of our colleagues on the relationships of COVID-19 and sepsis. But what is striking and what we have to bring to the policymakers, that even though we have this immense human burden of sepsis affecting 50 million people every year, still sepsis is not on the global political agenda in global health. We have to ensure that sepsis is reflected and prioritized in the ongoing discussions around the new pandemic treaty or the pandemic accord. And it is clear, also reaffirmed by the UNDP administrator and our other senior colleagues in the UN system, that without effective global sepsis response, we would not be able to achieve the universal health coverage, pandemic accord, antimicrobial resistance aspirations, and the overall health-related sustainable development goals. As the next steps and concrete steps, the Global Sepsis Alliance, in partnership with Sepsis Stiftung and other key players, including Virchow Foundation, Unite Parliamentarians Network, the Clinton Health Access Initiative, we have developed the Berlin Declaration that was adopted in September 2023 that consolidates the latest data and evidence and recommendations for policymakers. And this is a roadmap for our future action, how to scale up the historic 2017 resolution of the World Health Assembly that is currently implemented by less than 10% of the UN member states, and how to reinvigorate the global action on sepsis. The document is already endorsed by 75 international health organizations and partners, including the World Health Summit, so we extend our special thanks for the support. And as the next step, we would be releasing the renewed global agenda for sepsis in the beginning of 2024 as our common global strategy, how to tackle the challenge, the global threat of sepsis, in respect to the universal health coverage, sustainable development goals, and the overarching agenda for global health. So we kindly invite you, and of course we will be approaching you as we work on the new agenda, and this should be definitely a multilateral effort if we would wish to end sepsis and to really improve both the survival and quality of lives of the sepsis patients and the survivors. Thank you very much.
Yes, also thank you, Dr. Yashe, for these very encompassing introductory slides showing the real dimension of sepsis nowadays. That I'm surprised. I mean, as a pathologist, I don't see this at all. We sometimes, of course, see the end stage when people succumb to the disease, and then we do autopsies, but we don't have a real feeling for the frequency of this disease. So this is very important. I would like now to move on to our next speaker, who also gives an introduction on sepsis and why we need more awareness, which is Professor Konrad Reinhart, Professor of Anesthesiology and Intensive Care and former Director of the Department of Anesthesiology and Intensive Care at the University Clinic of Jena, and currently Senior Professor at Charité as well as BIH Visiting Professor. He also is the President of the Sepsis Foundation and founding President of the Global Sepsis Alliance. Furthermore, he's well known for his highly cited research on epidemiology, diagnosis and therapy of sepsis, and for improving sepsis awareness on a global scale, which will also be in focus of today's meeting and is probably one of the reasons that we have this focus today here at a meeting combined with COVID-19. Professor Reinhart, we are looking forward to your introduction on sepsis and sepsis awareness.
Yeah, thank you very much for this very kind introduction. I'm very pleased to see here quite a number of former colleagues who know teach me about sepsis, but also who fostered us in their positions as RKI presidents, etc., etc. But despite these common efforts, we are not there where we need to be, given the burden of sepsis that was just quite nicely described by our esteemed colleagues. And I can skip quite a number of slides because you have lined out the dimension, but the dimension is not only to be existing in so-called low-income countries, where indeed the incidence in some African, Asian countries, the incidence is up to 4,000 per 100,000 population. But look at the incidence of sepsis, and this is most recent data also from Germany, where we looked into the files and not what was documented in the ICD codes. So we have a problem. And Miriam mentioned this study, most recent report just came out at the end of 2022, and they found that the bacterial sepsis cases, according to their criteria, would make up the second rank as the second leading cause of death globally. Can you imagine that this was not on the agenda in 2000, before we launched the WHO sepsis resolution? Sepsis on the website of WHO and the Global Burden of Disease report was only there as neonatal and maternal sepsis, and it was not, as I said, in the Global Burden of Disease report. And I don't want to go into detail. And it's also, as already mentioned, in the report, which was driven with the support of the Global Sepsis Alliance, but foremost it was very important that after some time, our former health minister, Dr. Kröhe, put it and cared for to bring it on the agenda of the World Health Assembly in 2017. And also in this report, it was clearly mentioned that manifestations of septic shock can be the final common pathway of infections, not only with bacterial infections, but seasonal influenza viruses, dengue viruses, severe respiratory syndrome, coronavirus, middle, etc., coronaviruses, and yellow fever viruses. So, but this was not even aware when Ebola came, and it was even less. And this is most recent data from Massachusetts. And they looked over the period from March 1, where actually we had a meeting in one of the lecture halls addressing and mentioning we need to talk about COVID-19 and sepsis. But they have, within their electronic health record, found that at the same time in their hospitals, the incidence of admissions to the hospitals were always in the range of 8% of any admission, compared to 2%. How come? So that this silent pandemic, which we as intensivists realized, when I entered in the Benjamin Franklin, I had nothing heard about sepsis at all during my studies. There was no data on it, no guidelines on it, no advocacy, no research funding on it. And there was a time where it was very clear that infectious diseases and pandemics, which by the way have their danger because they are the final common pathway from any pandemic, is sepsis. And Sir William Osler, you may know, addressed this, that this is more burden than everything else. And unfortunately, if you look at these numbers, it's still true today. And the nice thing is that in the meanwhile, it's demonstrated that there are 4 major ways. Vaccination was already mentioned, clean care, early recognition, management as emergency, and this was set out, by the way, you may remember him, and he told me, I know what sepsis is as a heart surgeon, and he became active. He did the patronage for when we launched the European Sepsis Alliance. And it took me very long to understand why this was as it is. And it's, from my perspective, has to do on the dramatic decrease of the mortality rate from infectious diseases, sepsis, which decreased from 1900 to 1960, to 50, around 50 in terms of incidence, only interrupted by this pandemic. And what was it? Why did this happen? Because public health was established. Every state in the US, they had departments of public health. They fostered better sanitation. They fostered chlorination of water. They fostered the spread of vaccination as far as it was, and then use of penicillin, etc., etc. So, and ironically, the perception was, after World War II, that the fight against infectious diseases and the book of infectious diseases can be closed. I have no other explanation for this. And what I would also like to mention, because if this would, in many countries, most countries in the world, in the low and middle income countries, this can happen just by doing the same thing, what has been done more than 150 years ago, or 125 years ago in the high-income countries. And this is data that also sepsis incidence and death rates can be decreased without mentioning the word sepsis. The death rates in Australia and New Zealand decreased from 35% to below, in the range of 18%, just by introducing an education of early recognition of deteriorating patients and implementing critical incidence reporting just as a measure to which was very active also in the air industry. And if you do more, which is done in Australia, this is most recent data from the state of Victoria, because they had realized, of course, also that sepsis is still, with their instrument, a problem also there. And with their low mortality, which was 70.5% before they started this awareness campaign, the number of hospitals who followed what is called a sepsis pathway, which are 3 to 4 simple messages, like taking blood culture before antimicrobials, like doing a lactate, like giving the antimicrobials in the first hour, the mortality decreased from 70.5% to 11.3%. The hospital bed use declined by 3,500 days. Reduction of cost, 11.7 million Australian dollars. Cost for the campaign, 8 point, I think, return of investment, 6 times. And as these instruments and this understanding is not the case in many countries, but only in some, our mortality rate, based on this most recent Innovationsfonds study, is twice as high as, for example, in Australia and also in Sweden So we have not a resource problem, but an awareness problem and an implementation problem. And there is a different philosophy also in some of these countries. So the unassisted death of Rory Staunton, who hurt himself at a basketball, was sent to an emergency department after 1 or 2 days, was sent home again, was taken up, and later, 3 or 4 days later, he was dead. And these parents did not accept it. And what Governor Cuomo did at this time, just to make a mandate that every of the 179 hospitals needed to do exactly this sepsis pathway. These bundles, they were controlled, and this figure in the New England Journal tells you that any delay goes along again with an increased mortality. But overall, the mortality went down 14%, and then after 5 years, the mortality rate overall in the New York state decreased from 32% to 21%, which was not, and another measure of Cuomo in this case was that every child in the school in New York has to be taught in sepsis. And just to mention another thing, in children published in JAMA, their mortality rate where this bundle were completed in the age group of 0 to 17 years was 7% compared to those where the bundles were not completed. And when we checked the mortality rate in this age group, we had to realize that it's 16.2%. So there's a lot of improvement and possibilities also there. We are not good in voluntary quality improvement measures. I skipped this just to mention that also delay in surgical source control is time dependent. If it takes 6 hours, because we also have some surgeons here in the room, mortality rate is 28%, and if you do it later, it's 36%. So this confirms that this is a time-critical disease, and the explanation that 5 years of quality improvements efforts failed was that there was no support by the leadership of the hospitals, no support of the other disciplines, etc., etc. And there's data also, and I skipped this yet now more or less. Even also in primary care, any delay of antimicrobial therapy decreases the likelihood of survival. And awareness needs also happen in the community, because in Sweden they have data to check out how long it took if a patient who was consulting somebody outside the hospital, how long it takes to go to the hospital for active treatment. If it's greater than 24 hours, the odds of dying are 4 times higher. That's why we need also to educate the public on the early signs when an infection progresses to sepsis. It takes pretty long. And this is an Allensbach poll that we did last year, where we asked, among other questions, again, on the question, sepsis is always caused by wound infection. 2/3 thought that this is the case. The understanding that COVID-19 may also result in sepsis, less than 10%, and the same was true for influenza. And if you look also on the vaccination rates against influenza and pneumococci, you see that in all these other countries, not all, it's only compared, it's half as high, and only, so we have also a problem to counteract the impact of, next slide. And this is data from 2013. So there there are countries where it was that low than 7%, and it has not much. It has increased in some countries, but not in other countries. It did not. Why does not this work well? Do we have a problem with the battery also? Can you move, please? So if you look why we have been successful in the fight against sepsis, which is still a problem, but we can cure now cancer patients. We have been very successful in the fight against AIDS with an incidence of less than 4%. And this confirms what Virchow has said, that medicine has the obligation to point out the problems and that the policymakers have to take actions. And this was something what the cancer people in the 50s learned and did. They understood for any illness to rise to political prominence, it needed to do marketing. A disease needed to be transformed politically before it can be transformed scientifically. And they ask in this book, The Emperor of All Diseases by an oncologist, a moonshot for cancer. They asked for a Manhattan Project for cancer, and they said, Mr. Nixon, you can cure cancer. And there were actions. Next. So, and still there are issues. This is CDC data. I would be pleased if the public and our policymaker would be made aware, and this is not such different from what we have. I think we have no opiate deaths in this range. Sepsis kills more Americans. I don't need to repeat this. So it's obviously, we have an awareness problem. Next. And one back. So, no, one forward. So, and this is from Moshe Nachavi, where he puts together, and this confirms that we have a very, we need fight AMR, definitely. But we must not, and also these people die from sepsis, which is not known. And that's why we are very grateful to Lauterbach that he has brought our proposal that we need to synergize the fight against AMR with the fight against sepsis, but because we feel that often in the meanwhile, antimicrobials are withheld not to increase AMR in patients who would badly need it. And one sign of this, and I found this only, that the EU Commission, who have several statements on AMR, and this is their latest fact sheet, and they argue AMR causes 35,000 deaths every year, and this leads to high costs of $1.5 billion. And next. And they rightly invest a lot in the fight against AMR. The German government has rightly funded the GARP hub here with 130 million alone. And if we would have comparable investments in education people on the early signs of sepsis, on the efficacy of vaccination, we would be in the same range as other countries are. And as long as nobody has understood what these people have in common, I could mention Annalena Baerbock, I could mention Bill Clinton, I could mention Madonna, as long as we have an awareness and an advocacy claim. And with this, I am at the end just to reiterate what Sir Lyndon Donaldson has said. When we achieved this sepsis resolution, the public and political space needs sepsis to come in order for things to change. And I thank you for your attention, and I think we will have or should have a fruitful discussion about this, how we can make this happen.
Yes, Professor Reinhart, thank you very much for these deep insights and the background that I think we will pick up later again as well. And we are now looking a little bit at the other side, COVID-19, viral sepsis. And it is my pleasure to welcome Dr. Uzma Syed, a specialist on infectious disease in Bayshore, which is on Long Island. I just found it on the map, quite in front of Fire Island, so quite a nice location in New York. And she's partner of South Shore Infectious Disease and Travel Medicine Consultants. She also is chair of the COVID-19 Task Force and director of the Antimicrobial Stewardship Center of Excellence at Good Samaritan Hospital Medical Center. I hope I said that all correctly. And furthermore, she is board member of the United States Sepsis Alliance. Importantly, I think, or I assume what you may be talking about today is that you are editor of the book on COVID-19 viral sepsis, as well as author of some of the articles. Welcome to Berlin. We're looking forward to your keynote lecture, Learnings from the COVID-19 Pandemic.
Hello, good evening. Thank you so much for that warm welcome. It is really my absolute pleasure to be here in Berlin with esteemed colleagues here in this very special meeting and very important topic that we are in fact discussing here today. So I was asked to essentially share my personal story of COVID-19 and being on the front lines during this pandemic, exactly what were my experiences, the motivation behind this book that was just discussed, that was recently published. And you've had a lot of background on sepsis and COVID-19 and the connection with viral sepsis. So in the next half hour or so, I mean, I could take hours to talk about my firsthand experience of being on the front lines of the pandemic, but I will highlight this and in the next half hour and kind of take you through this timeline of the journey. Some of you may remember this very well, and for others, this may be a distant memory, but I'll walk you through the timeline of exactly what it was like from my perspective and in being in my shoes and my eyes of this pandemic. So let's go back to December 2019, when we first started hearing about cases of this pneumonia of unknown etiology in Wuhan, in China. Patients were really showing up to hospitals with interesting lung findings on their scans or respiratory illness. No one really knew exactly what this entailed. The market was closed down. We really had just little bits and pieces of information that was coming out for the rest of the world. Between December 31st and January 3rd, there were about 44 patients that were reported to have had this respiratory illness of unknown etiology. On December 24th, a sample was actually sent about 500 miles away where the genetic sequence of this novel virus was very close to SARS-1. And on December 31st, they had mentioned that there was, in fact, at this point, no evidence of human-to-human transmission. Well, we know that on January 11th, WHO had said that they had received the genetic sequences for this novel coronavirus, at that time 2019 nCoV, and it was made public very soon after that. So if we go through a little bit of timeline in January, we see what happens. On January 13th, there was the first case of coronavirus outside of China in Thailand, and this was in a 61-year-old woman. And what was very interesting about this at that time was that this woman actually, in fact, had no contact with the market in Wuhan. Outbreaks then started occurring throughout China, and there was, in fact, then concern about human-to-human transmission by January 20th. And 198 cases were reported, and China did then, in fact, declare human-to-human transmission. As of January 23rd, we had 571 cases that were reported, and Wuhan then quickly went into lockdown. January 30th, the NIH had cultured the virus from the first US case, and had started doing its research. And also on January 30th, International Health Regulations Committee declared the virus a public health emergency of international concern. Well, being in infectious diseases on the front lines as a clinician, since December, I started losing sleep. I had significant anxiety and concern that this could be something that would arrive on our doorstep. It was rather unfortunate at that time that my colleagues, even whether it be in infectious diseases or in medicine, were really nonchalant and not fazed by this at all. As January came around, I started getting more and more concerned, and I really started escalating this and ringing the alarm throughout the health system, where I practice at 3 different hospitals, large hospitals in New York. And I went up the ladder through the associate chief medical officer, the chief medical officers, the chief operating officer, the vice president, and finally the president of not just the hospitals where I was practicing, but the entire health system, to really bring to light the fact that this could be something really significant that could arrive on our doorstep. Well, unfortunately, life was going on as usual in New York, despite the alarming cases worldwide. You found yourself in these conditions very commonly. Crowded indoor gatherings were happening, sports events, concerts, restaurants, bars. Life just continued as usual. By February, we saw that there was a significant amount of cases that were happening outside of mainland China. You can see in Europe and outside of mainland China, where there were cases, as I mentioned before, in Iran. This was still not concerning for the community in the US. By March 9th, we had over 110,000 cases worldwide, mostly occurring in Iran, Italy, US. And in the United States alone, we had over 600 cases that were reported, mostly in New York, Washington, LA, and Boston as well. And by March 11th, deeply concerned by the alarming levels of spread, the WHO had made the assessment that COVID-19 can be characterized as a pandemic. So what we once saw very commonly on the left here, scenes from Times Square in New York, very, very common for us even up until that point, very suddenly turned into these kind of scenarios worldwide, and especially in New York, where we have such densely populated communities and large population. Scenes like this really seemed like something out of a zombie apocalypse movie. And it was really, really quite concerning, where in New York City alone, the public schools in New York City are the largest schools in all of the United States, where we had over 1.1 million students. The schools had, in fact, shut down. The city and the state went into lockdown, and people started sheltering in place, and you can see scenes like this happening everywhere. Well, to really stay up with the surge that the hospitals were facing, we saw at this point, by the time we went into lockdown, the cases were really astronomical. There was widespread disease throughout the country because the virus, in fact, had been spreading. And to really brace for this and to keep up with the demand that was placed on the healthcare systems, we had all of these kind of scenarios where the Javits Center was quickly turned into a patient care area. The USNS Comfort was also there so that we could properly triage and care for patients, because there really just wasn't enough supply to keep up with the demand that we were seeing. And this was really, really concerning. Scenes like this occurred throughout the country, especially in New York, where we were hardest hit. It was not uncommon to find makeshift tents in parking lots of hospitals and healthcare systems all over, because we just could not keep up with the demand of the number of people that were coming to the doors of the hospitals, acutely ill, severe illness, where they were requiring hospitalizations. And we had to properly triage these patients and try to keep the patients that were healthy, that were immunocompromised in the hospitals, protected from this new respiratory illness and people that may be arriving on their doorstep. And where I practice in Long Island, New York, as you know, was very much a hotspot, not only in all the boroughs that we have in New York City, Queens, Brooklyn, Staten Island, but in Long Island as well. In fact, 3 of the hospitals where I practice were considered hotspots, and you saw a significant amount of cases that were occurring. The population, about 3 million residents, but at this time, early on in the pandemic, already we had over 29,000 cases. And these cases just continued to climb. By May, we saw really, stark changes with widespread disease. We were very much used to seeing the Johns Hopkins tracker. We were used to seeing the WHO dashboard. And we saw that from March, where we had over 100,000 cases, we went up to over 3 million cases just in a matter of 2 months. And you saw the widespread disease that we had globally and the concern that this was. What did we do? We sheltered in place. We went into lockdown to really flatten that curve. We talked about this so much because there was so much impact on the healthcare system where it was on the verge of collapse, and we just could not keep up with the demand that was there. And we all just talked about sheltering in place and trying to catch up and buy some time because we didn't know much about this virus. We didn't know about the diagnostics, the mode of transmission, the treatments, and we need to learn and we need to really ease up the restraints that this was placing on our healthcare system. Well, pandemic response during these challenging times was quite difficult. We found ourselves in a very evolving situation where knowledge was changing day to day. We were learning about this virus on a daily basis, on an hourly, minute-to-minute basis. We talked frequently about how we were building the plane as we were flying, and it was very, very challenging. We didn't know about the modes of transmission. We didn't know, was this droplet, airborne? We didn't have resources. We had limited supply of PPE. We were repurposing our PPE. We find ourselves in really unprecedented times, and it really became even more challenging for us. We didn't have the proper therapeutics. We didn't know how to care for our patients. Our traditional methods were just failing us, and every day we were losing more and more people, and it was very, very frustrating for us. We started our clinical trials immediately, as quickly as we possibly could, to really come up with potential solutions. However, our traditional methods of science were just not good enough. We didn't have the luxury of time. We had to speed things up as much as we could. We had the patient demand and we had the population, but we just didn't have the luxury of time. And in all this time that it took to really come to some clinical evidence-based medicine of proper therapeutics, we kept losing people along the way. Infection prevention strategies were very challenging. We didn't know what kind of messaging we should give to the public, and this became really challenging because it further led to mistrust towards science. We had limited supplies of PPE, and we were trying to really harbor those for the frontline workforce. However, this became challenging for the community that was getting mixed messages at that time. The policy making that we were writing, we were doing it, writing and revising it on a daily basis, sometimes on an hourly basis. Things were changing minute to minute, and this is exactly what we felt like. A friend of mine did this artwork here, and it really shows the strain of healthcare workers throughout the globe, where we felt like we were fighting this uphill battle. We had the constraints of everything that we have traditionally, on top of that working during an evolving pandemic. We had the fear, we were asked to be on the front line of this pandemic and risk our own health, but we had the fear of bringing something novel, something unknown back to our families and our friends and our loved ones, and how could we keep everybody safe? We cared so much about our patients, but how could we do things to really save those patients? We had never seen this degree of morbidity and mortality all at once, where for all purpose reasons we were in a war zone. All of these things were really fighting against us, and we felt like we were just in the most unprecedented times. This is just, what a typical day looked like for me with our team. You can see that there's some smiles there behind the masks, but I can tell you personally, there was a lot of anxiety, there was a lot of fear, there was a lot of exhaustion, and there was limited supply of PPE. So we found ourselves doing this and repurposing our PPE all the time. We finally had some bright light where we heard that there was going to be an RT-PCR that was EUA approved, and we could finally start to have some diagnostics for our patients. And this arrived in February in New York City. However, unfortunately, these test kits failed, and once again, we were left without anything to really hang our hat on. And what did this do with the bureaucracy that we had from the CDC and trying to get FDA approval for private companies to really develop test kits? We just kept losing time. And all that loss of time just kept meaning we lost more patients. We had a difficult task of masking. We didn't know, are we dealing with droplet, airborne? What do we tell our patients? What do we tell the community members? What do we tell our healthcare workers that are on the front lines? However, we don't have enough supply of PPE or N95 masks to protect our frontline healthcare workers. We had the community reach out and supply PPE for us as much as we could, but we knew that there was global shortages, and we realized very quickly how we were always relying on the international community. Well, when the world went into lockdown, we had no reserve of our own. And again, this led to further challenges for us. We talked about ventilators. We found ourselves really limited with our supplies as patients were coming in severely ill when they were sick enough to behave like our septic shock patients in the ICUs, respiratory failure, ARDS, needing to be on a ventilator. We found ourselves having shortages with ventilators. I mean, this was unprecedented times. We never had this many sick patients all at once. And very quickly, then hospitals were required to report their supply of their ventilators. And we saw quickly how other companies actually went into motion to really help with this supply and demand issue. We had companies like GM, Ford, Dyson, Rolls-Royce, and Tesla really working now to shift their production to ventilator production so that they can really keep up with this demand. In the United States, the approach for the pandemic response was extremely decentralized. And you can see basically each state and each territory and city was responsible for their own pandemic response. And this was really up to the public health departments. And what this did actually, because there was a lack of centralized approach to the pandemic response, this led to massive spikes in cases. And it was really, really difficult because we had fragmented care, spikes all over, and really what it did was it just led to more outbreaks locally and basically left every region of the country touched by this virus. There was really no region that was not affected. We then started seeing the structural racism that started emerging. We knew already that there was significant inequities that persisted in structural racism. However, the pandemic really exposed this deep-rooted structural racism and health inequities that we had. And it was really, really alarming. We saw firsthand how Black and brown communities were most impacted. Our hospitals were flooded with patients, and it was completely inequitable. And you can see how they were coming in with the worst case scenarios. They were in the worst shapes because they were presenting with sepsis and severe respiratory syndrome from this illness. And we see here the stark differences between the minority communities and how they were impacted with COVID-19. And there's a reason for that. Not only is there structural racism that's been around and health inequities, but the pandemic really highlighted just how rampant this was. We had an essential workforce, and you can see that the minority communities were part of that essential workforce. They didn't have the luxury of working from home. We had our transportation workers, we had our grocery store workers, we had our meat packing factory workers, we had our bus drivers, we had people that worked in nursing homes. They didn't have the luxury of working from home, and they were constantly exposed, not having PPE, not having methods of protecting themselves, not even having access to simple masks or hand sanitizers. And you can see here that oftentimes the same population was always traveling by public transportation. They didn't have the luxury of driving to work on their own. They were in multi-generational households, so when one person was sick, they didn't have the luxury of isolating in their own bedroom, using a separate bathroom, and so the virus continued to spread in these communities. And then structural racism and health inequities, we had people that don't have the luxury of having child care or elder care where they were able to get to their doctor's appointments, where they were able to keep up with their healthcare maintenance. So you're already dealing with a population that already had an increased risk of diabetes, increased risk of obesity, increased risk of being exposed to pollution and living in crowded conditions. So all of that is putting them at risk of having worse outcomes with this novel virus. And then we found ourselves in an infodemic of misinformation and disinformation, and this became even more challenging for us as we're dealing with this pandemic. We were trying to keep the messaging clear, we were trying to keep people healthy and safe. However, there was this negative force that was working against us and just countering the science, the information from science, and there was this frank mistrust in science. In the beginning, when I would drive to work, I would see these lovely signs that were placed all along my passage to work about supporting healthcare workers. We had these beautiful signs. We had food that used to get donated, people just outpouring of support from the community. In New York City, people would be on their balconies, play instruments and sing and clap and cheer for healthcare workers. Well, things shifted very quickly as the misinformation continued to spread and public health messaging was changing because of the evolution of the virus. There was a mistrust in public health community, and people just kept thinking that public health was actually lying to them and that leaders in science were evil. And so this created even more difficulty for us as we were trying to keep people alive and trying to promote health and well-being of all communities. During the pandemic, we did these clinical trials that I mentioned before. I was able to get 2 clinical trials running at my health systems for antiviral remdesivir and monoclonal antibodies. And quickly, we started enrolling patients, and we started having data, and the data guided us and showed us that there was some promise. And so there was a little bit of light, at the end of the tunnel. However, we also started seeing that for our sicker patients that were behaving like our septic patients, that there was some repurposing of drugs that were actually, in fact, helping them. Something as simple as steroids were helping some of our sick patients. We saw different modes of inflammatory blockers that were helping our patients as well. And this really made us think, and made me think specifically, that these patients that are in our ICUs are really behaving like our septic shock patients. But nobody's really calling it that. People are so focused on the virus and not really realizing, because they're always thinking of traditional septic pathways being bacterial pathogens, and just because we're dealing with a novel virus, it's just not given the entity is not given the name that it really needs. And over here, we can see here that it was mentioned that surviving severe COVID-19 means surviving viral sepsis, rightfully said. Now, viral sepsis, as we mentioned before, sepsis itself affects over 50 million people globally, and it's responsible for about 20% of global deaths. Viral sepsis, specifically due to COVID-19, is underreported and underdiagnosed. We know that the modes of really treating this is directed at prevention, and that we got to with obviously our public health measures and non-pharmacological interventions such as masks, social distancing, but also then vaccines. There's consequence of severe viral sepsis and organ dysfunction, hemodynamic compromise, respiratory failure I mentioned before, ARDS, mechanical ventilation, demand ischemia on the heart, acute kidney injury, and encephalopathy. So that brings me quickly to why this was a passion project of mine. Being on the front lines, seeing the severe impact that I saw in my patients in the ICU, who were the sickest patients of mine, and just not having the right modality of treatments for them, I started thinking that we really need to recognize this entity that is viral sepsis, specifically in COVID-19. And I thought this would be the opportunity to really highlight that, and that's something that we need to recognize. And we know that this is severely underreported. There's traditionally other viruses as well that cause sepsis, but we never really think about viral sepsis the way that we should be. It's always the traditional bacterial pathogens. So if you're looking at just some of the etiologic agents of sepsis, you can see it's not just bacteria, but other types of infections as well. And this is something that we need to really just promote education for people to be well equipped with this knowledge so that they know how to treat. Not every patient in the ICU with sepsis needs antibiotics or antimicrobials, because you need to treat the underlying cause. So I think that's the important thing that we have to remember. We knew that COVID-19 has multi-organ effect. The more severe the infection, the worse the outcome for the patients. Not only are we talking about sepsis, but post-acute infectious sequelae, just like other infections in the past. And we saw this clearly with acute infection and chronic infection and its consequences. Now we shifted from having some therapeutics that we knew were working to really having some amazing breakthroughs in science to have vaccine development so that we can really save more lives. And we had so many different vaccines that were in clinical trials. We had different vaccines that were approved, and during 2021 we started then quickly rolling out vaccines so that we can really save more lives. Well, although this was a silver lining at that time, we did then start seeing some safety signals, and again, this led to more mistrust from public and community, where they kept thinking that this is a novel vaccine for a novel virus, and it was rushed and it wasn't tested enough, and people were just not comfortable taking these vaccines. And we saw disparities again. The patients that were being hospitalized were much higher rates of unvaccinated people than vaccinated people. So there was a stark divide and stark disparities. There were some cases of myocarditis, following these vaccinations, especially in adolescents. So again, there was vaccine hesitancy. We knew that the virus itself can give you significant myocarditis, and so that was the messaging that we were trying to get across, to really have more vaccine uptake and really combat this vaccine hesitancy. Well, between March and August, we also saw that children were affected with COVID-19 far more than they were previously, and this was attributed at that time in 2021 to the Delta variant. We saw that it was much more transmissible, and at this time we saw that children who were unvaccinated were 10 times more likely to be hospitalized than vaccinated adolescents. And as the virus kept spreading in our communities, we were trying to promote vaccine uptake. What this did was we just kept seeing more and more variants. We went through so many different stages of this pandemic, and the virus just kept mutating, and we just kept seeing community transmission growing. And despite the vaccines, we saw that there was significant vaccine inequity. And globally, we had over 5 million doses of this vaccine that was delivered in 2021, but we saw that only 1.9% of vaccines were actually delivered in low-income countries. So disparities persisted not just locally, not nationally, but globally throughout the entire pandemic, and it was really evident. This over here just shows more share of people who are vaccinated as of September 2021. And again, you can see that there was significant inequities. There were places where people hadn't even received a single dose of the vaccine. And then we had, as the pandemic went on, we were seeing in resource-rich countries that people had already received their boosters. And meanwhile, you had people in other countries that hadn't even had access to their first dose. So to combat this, a lot of countries, United States and Europe, were really trying to work with COVAX to have, combat this vaccine inequity. Unfortunately, we really didn't get to the targets that we needed to be at. And again, there was just unprecedented times that we were dealing with during this pandemic. Now, speaking of inequities, we also know that there are so many communities who are displaced globally. According to the UNHCR, there's approximately 82 million people who are forcibly displaced. And the tragedy with all of this is that about 42% of people who are displaced are actually children. And this puts children at risk to be exposed to the most vulnerable and be most vulnerable diseases and be most impacted by this. And this was really stark, despite sheltering in place, despite the conflict, despite the global scale of the pandemic. We still saw that areas of the world where there was conflict, people were really just suffering because there were stark inequities that were there. There's lack of access to healthcare, so there isn't baseline healthcare maintenance, and then trying to get vaccines into these areas where there's, people are displaced is really challenging. Oftentimes, in areas of conflict, there not only is there lack of access of healthcare for people, but oftentimes these medical supplies and medical equipment is destroyed. Healthcare workers a lot of times are targeted in these regions as well. So it's really, really challenging to really get basic healthcare into areas where people are living in conflict. On top of that, these scenarios and these situations is where people actually find infectious diseases spreading more rapidly. A lot of times these are crowded conditions, whether it be refugee camps or detention centers. People find crowded scenarios, and this is where infection spreads even more rapidly and more quickly. And that, on top of not having access to basic health care, is just a bad combination overall. And sometimes it can be as simple as not having just basic civil documentation and not having registration for people to not be able to access health care of any kind. Now, the WHO did release the largest global collection of health inequality data, and I think this is really important because I think if there's something that we've learned from this pandemic, it's that we need to really do better. We need to do better for the entire global community as a goal. And we've seen how much positive impact we can have as the global community comes together. Just on the vaccine development front, we saw how the entire global community came together for a singular purpose and how much advancement we had in science at that time. And we need to really invest more and do better to reach every single community so that nobody gets left behind. And you can see here this global divide that we saw in the COVID-19 vaccination rates from the survey from the Kaiser Family Foundation. It's very obvious that high-income countries had a stark difference in vaccination rates, much higher uptake in vaccine delivery and access than low-income countries here, which are listed down here. Well, in conclusion, what are some of the lessons learned from my perspective during the COVID-19 pandemic? Well, there's a lot that we have learned, and there's a lot that we can think about making advances for science and for future pandemics. Open communication is key. It's really important that from the beginning we share information widely, and we make sure that everybody has access to this information. We invite experts and key stakeholders to the table. This is usually very effective when you have a multidisciplinary approach where everybody who has some part of a health system is there. So whether you're talking about the C-suite level to engineering, who's dealing with, the filtration in a hospital, to the lab technicians, the director of the lab who's dealing with how to process these labs, tests that we're getting for diagnostics, to our infection preventionists. So everybody has to be at the table, the clinicians, infectious disease experts, intensivists. There has to be open communication and there has to be buy-in from everyone. So if we all work together collectively, we're going to have much better outcome for the health system and for communities at large. We saw that telemedicine expanded significantly during the pandemic, and that was something very positive. Wherever obviously people have access to these resources, we were able to help communities. Instead of sending patients to the hospital, we were able to triage them with telemedicine. So this was something that was really, really a good innovation, and it's actually continued since the pandemic. Data analytics was very important. We used electronic health records to our advantage. When we had surge capacity at our hospitals and our health systems, we were able to see where, using EHR, where could we accommodate patients. We could also see where we could create new spaces for patients. So it was really important that we could see the amount of supplies that we had on hand, whether it be PPE or ventilators, to the actual space for our patients in our hospitals. Adapting to the situation was very important. So once again, we had limited supply, limited configurations for isolation rooms, specifically airborne isolation rooms. But what did we do? We created new signage, we created new spaces inside our hospitals, sometimes outside in our tents, and we got portable HEPA filters. So we modified our behaviors, and we really adapted to this changing scenario that we found ourselves in. Recognizing viral sepsis. I think this was one of the most important things for me and for many of my colleagues, where I talked about it at length. This was the impetus for this book that I published, because we need to do better. We need to understand that there's other pathways to sepsis, not just our traditional bacterial pathway, because then we can do better for our patients. Depoliticizing pandemics. This was really key. In the United States, in Europe, globally, throughout the world, this was very charged and very political, and that was something very frustrating for public health experts, for people in science, that when we were trying our best to save every single patient, there was this opposing force from politics to really undo all of this public health messaging that we had. And so it's really important that we reach communities and we try to get that trust back into public health. Equity needs to be at the forefront, as I mentioned before. The world is not an equitable place, and we need to do better. And then global collaboration is really key in all of this. And if we all work together, we can really come up with some positive outcome and have more impact for the health and well-being for all communities. Thank you.
Please stay with me for a while.
Sure, of course, yeah.
So thank you very much for this very comprehensive overview. I think many of us had memories of related pictures and what we saw during these pandemics. And one thing that I think is very interesting, at least from my perspective, I very quickly forgot again what all these restrictions were about, with these wearing masks and so on. I have almost no memories of the bad times of this pandemic, but actually the lessons learned, I think, are important to remember, and also to do some helpful insight for pandemic preparedness for the future, and also for our related topic, sepsis, to not just let this pandemic pass without any lessons learned. Yeah. So thank you very much for this. We have a few minutes for discussions. Are there any questions from the auditory?
How realistic is it to depoliticize such pandemic? Because the politics is very important in this. So everyone is looking, what do they say, what do we have to do? And the politics has to decide what to do. So you can't depoliticize it.
That's an excellent question. I think what we have to do is we have to have partnership. We have to have this conversation. Everyone is looking to our leaders in government to lead the way, and it's important that the public health experts work with government to have the same messaging. It's just counterproductive when it's opposing forces, because who suffers at the end? It's the people, and we can't have that. So I think it's really important that we have collaboration and try to have same messaging, because at the end of the day, we just care about the health and well-being of communities.
First, thank you for your nice lecture. I have a critical question. Can you explain the difference in mortality in your country in comparison to Europe?
The difference in mortality? I think what I'm going to preface that by is that a lot of numbers, the data that we have is actually really underreporting. We don't have, we've stopped diagnostics, so we're not capturing specifically, even the actual COVID numbers, whether it be in the US or other places, but we had stopped doing that a long time ago. And then with the home testing that had come to be, people are really not being counted for. And if you think about it, most people, we're now on a baseline of people who have been exposed and have natural immunity, and on top of that, vaccinated. So we're dealing with a different baseline population. So initially, in the beginning stages of the pandemic, there was a lot of emphasis on mortality and what's happening. And during the different stages of the pandemic, that has changed so much to the point where people had pandemic fatigue. They don't want to talk about COVID. They don't want to think about it. They don't want to test themselves if they even have any symptoms. So I think a lot of that has to do with the actual numbers that we have, because they're really underrepresentation of, in fact, the real data.
Because you have rightly asked the question of depoliticization, and our learnings here has been we want to have the same passion of the policymakers which they provided on the pandemic. And of course, it's very true what you have said, that they need to speak the same language and not to do it contrary. But what I learned, obviously, and this goes along with the question of the quality of healthcare, I was surprised to see from this data from Massachusetts, I haven't shown it, but it's in the same paper, that the mortality from ICU-treated bacterial sepsis and COVID sepsis-treated patient at the end was 15%. Both groups. In the very beginning, it was higher, somewhat higher for the COVID. There was a learning curve. And I just wonder, and perhaps Björn Weiss might also ask the question, what is the mortality rate of the ICU-treated patients with COVID-19 sepsis? Do we have this data?
Dr. Jessen had a question, I think.
Thank you very much. It was an excellent lecture. It was very New York, actually. I was wondering, how did you manage the inequalities of your health system? Like you were talking about racial, structural racism and stuff, but if you take into account, for example, that around Washington, D.C., the HIV infection rates were almost as high as in South Africa, so then there's low-income country or low-income areas within the United States. Did you just open up the system and everybody could get diagnosis, treatment, and intensive care and so on, or how did you manage?
So when we talk about inequities, I saw that firsthand being one of the hospitals, one of the larger hospitals where I practiced was in fact in that hotspot, was in fact in an area where we had a lot of communities that were from low socioeconomic status, and they were those frontline workers that were exposed, and that's what we saw in the hospital. So to really, work with that was an eye-opening moment for me, especially in March when I started to see the impacts that we were having. And this persisted throughout the country, throughout the world. You saw pockets where people had, access to healthcare, and there were areas in the country where people didn't have a pharmacy near them. They live in pharmacy deserts. They didn't have clinics near them. They could not go for their healthcare maintenance easily because they had to change 3 buses, find a babysitter, have some call out sick from their work. Well, when they did that, they were losing pay to pay their rent. There were so many challenges that they had, and that just led to a baseline of having higher risk for being, having severe COVID. So once they came to the hospitals, we used everything in our power to really make sure that we drove down those inequities. Everybody had access to all the same medical care that any other patient would. But there was challenges with that as well, because now we had patients from different ethnic minority communities. Some of them didn't speak English. You know, there was this mistrust. You know, if you have a clinician who doesn't look like you, who's not from your community, who doesn't speak the language, you're not going to trust them to accept going into a clinical trial for a life-saving therapeutic, because who are you? You're a foreign person to them, right? So we had to build that trust, and you know, we really I worked heavily on doing a lot of research and work on this in the United States during this pandemic to really make sure that people have access to care. We use translation services. You know, we really worked on making sure that the workforce is diverse, whether it even be in medicine. We need to make sure that there's more diverse and minority population that are physicians so that they can reach those communities, and really just promoting healthcare maintenance and having information there in different languages for patients to go home with, instructions for them, for their family members. So it was, you know, it was very, very challenging, but we found different solutions, and the goal was to not just let it end when the pandemic, you know, is no longer a public health emergency, but to continue that forward so that you're building that infrastructure to make sure that people have good health care and baseline, you know, access to health care. You know, we had those mobile pharmacies that went around to reach people. We did vaccinations at places of worship. That helped us tremendously. You know, people would go to churches, synagogues, mosques. We'd have community. They would trust their faith leaders. So we did vaccination campaigns at these places, and it was wonderful because we want to do that a next step, make sure that these people are coming back for their basic healthcare maintenance, their blood pressure check, their cholesterol, their immunizations, everything.
Maybe I have a related question. So you mentioned, and you showed this on a very nice slide, that in underserved areas, particularly in third world countries, there were huge inequities in regard to access to vaccines. And I mean, of course, these cultural topics, they can be helpful if the vaccine is actually available. But what would be a good strategy for future pandemic situations to improve access to vaccines on a more global scale? Is it that we have to change our policies? So if these vaccine programs are financed by governments, then we have to oblige the pharmaceutical countries to also open it up to more underserved areas, or what would be an idea for that?
That's a great question, and I think that's something that we really have to look at, because we can see that we didn't do well this time around. And what we saw, again, from a small local scale to even a global scale, was, again, the difference between the haves and the have-nots. The people that had access, that had resources, you know, they were front of the line to get their vaccines, and then the people, unfortunately, who didn't have access were always forgotten and always left behind, and they were the ones that were, you know, suffering as a consequence. So it has to be a multi-pronged approach. It has to be, you know, the buy-in from the governments, and also you have to understand that despite some places having access and having delivery of these vaccines, there was mistrust from the community. So the vaccine may be there, but people are not willing to take the vaccine. So then who do you have getting the right messages across to the communities? It could be faith leaders, it could be community leaders. It has to be a joint, combined effort from all key stakeholders to really have this positive impact.
Another question.
How important is this? I remember in the beginning there was the try to find out who infected whom and who spread it where, and it went from there to there. And how important is it really? What information did this give, or is it just not important for the next pandemic?
I mean, for the next pandemic, it really depends on which kind of pandemic we're dealing with, what kind of infectious disease it is. But, you know, for this specific, you know, SARS-CoV-2 virus, I mean, essentially in the beginning, like I mentioned before, we went into lockdown, we did that flattening the curve, and we did all this, you know, testing, tracing, isolating, and contact tracing to really try to contain this as much as possible. We saw very quickly how this was something that was not containable, because you had asymptomatic people spreading the virus, so it got to the global scale that it did because of that. But in the beginning, we had to really try to, you know, reserve our resources and save as many lives and really kind of get it under control just till we got a grasp on things and to figure out exactly what we're dealing with. And at that time, it was very, very important, this contact tracing, because we could tell people if they were fortunate enough to be able to, you know, quarantine, had they been exposed, you know, and test themselves. Eventually, when we had the test kits, you know, those measures were really, really important from, you know, public health perspective.
Yeah, thank you very much
no
again for this fantastic overview. Yeah. All right, so we're moving on to our discussion panel, and let me restructure this a little bit. If I can move this out of the way, then we have space for one more chair, which is actually missing. And then first of all, I would like to re-welcome Dr. Yashi and Professor Reinhart to take your seats. And I would also like to welcome our additional guests, Dr. Shevin Jacob. Dr. Shevin Jacob is an infectious diseases and sepsis consulting physician and lecturer at Liverpool School of Tropical Medicine in UK. He has a research focus on sepsis in adults and in resource-poor countries. And if I understood correctly, you're currently living in Uganda. Dr. Jacob is also Secretary General for the African Sepsis Alliance that is dedicated to improve outcomes in sepsis patients. And he is co-founder of the NGO Valimu, and that supports the Uganda Ministry of Health in training for management of severe illness. Welcome, Dr. Jacob. Then I would like to welcome Professor Leif Sander. I think most of us know Professor Sander. He's a professor and chairman of the Clinic of Infectious Diseases here at Charité. He completed his medical training in Hanover and scientifically trained in the US at Icahn Medical School at Mount Sinai in New York City. And his scientific focus is on infectious immunology, vaccinations, and I assume more recently also COVID-19. Welcome, Professor Sander. Then I skipped one colleague, Dr. Iris Hunger. Wunderbar, perfect. Dr. Iris Hunger is a philosophical doctor of political science and holds a master in biochemistry. She's deputy director of the Center for International Health Protection at Robert Koch Institute. The center cooperates with other countries and stakeholders of public health in order to strengthen public health systems and optimize records to public health threats. Dr. Hunger also welcome here. And then I have Privatdozent Dr. Weiss, is Deputy Director of the Department of Anesthesiology at Intensive Care at Charité and head of the Telemedicine Unit. He received his degree at Philipps University Marburg. His research focuses on virtual care and sedation in the ICU, as well as quality improvement. And he's nominated for the COVID-19 intensive care group at Robert Koch Institute. Welcome, Dr. Weiss. So I just grab an additional chair. This is semi-professional. So maybe let me just ask some open questions, and I will try to address it to some of you, but maybe we keep this discussion relatively open. Let me start with Professor Sander. And sorry, where did I? Here. So one thing that I found surprising when I was preparing and reading about COVID-19 and sepsis is that in literature, secondary bacterial sepsis in COVID-19 is actually not really mentioned that much. Actually, you see that it's written that this is a relatively rare condition. However, during the beginning of the COVID-19 pandemic, we found in a small autopsy series that actually many of the patients that had died subsequently to COVID-19 or severe illness in COVID-19 had bacterial pneumonia. Is there a reason, or what are your experiences in COVID-19 patients? Are secondary infections a major cause for sepsis in these patients, or is it rather the viral sepsis itself that causes the poor outcomes in these critically ill cases?
Well, thanks for this excellent question. So I think indeed, in the beginning, I think many people overestimated the frequency of bacterial superinfections. Lots of antibiotics were actually used in the beginning because we saw high levels of inflammation, high CRP levels, and so everybody was prescribed antibiotics, at least in the first few weeks, until we sort of recognized this is primarily caused by just inflammation to the virus. Indeed, I mean, we've worked extensively on the pathophysiology of severe COVID ARDS. And I think since it also causes quite substantial fibroproliferative responses in the lung, I mean, we worked on this together, right? So I think especially patients on ECMO, and so stay on the ICU for quite a long time. So and a secondary episode of bacterial infection is often what sort of pushes them over the edge. However, I think upon initial presentation, most of them did not have bacterial superinfection, but quite clean viral ARDS. However, I think since we've now established broad population-wide immunity, we are seeing more superinfections presenting as sort of the initial presentation, at least on the floor as well as on our units, which is, I think, now a bit more like what we see with flu. So we're just the nature of the disease actually has changed a little bit, and that is, I think, due to the fact that now this is no longer a virus that encounters a completely immune-naive population, but it encounters pre-immune individuals, and then it can lead to these secondary, and probably immune responses have altered a bit, and then in some vulnerable individuals, it can now lead to superinfections, and we saw quite a few in the last season. We're starting to see some now, just like with influenza. So that would be my take.
And maybe a short question in addition. So is that also that since the beginning, when no vaccines were available, and we had a blunt confrontation of our population with COVID-19 or with SARS-CoV-2, compared to now, whereas most patients, I assume, that are treated in hospital had one vaccination or had the infection before, do you see a shift or a switch in the type these critically ill diseases progress, or is there a difference in management as well, or are the complications different when these patients make it to the ICU?
So I think you're touching on a very important point, because all our therapies that we're using, all of them were basically developed in the situation in immune-naive patients. So the fact that we give dexamethasone, for instance, we haven't rerun those trials on individuals that experience COVID with the background of pre-existing immunity. Now, I can just speak from experience right now. We have a handful of cases on the ICU. The radiographic images look very much like in the beginning of the pandemic, only that most of these individuals have some kind of underlying immunocompromise or some other comorbidity that sort of puts them at higher risk. So I think it's an important topic for us to clarify whether our treatment algorithms will actually hold up and be the same now that basically the population, so the host for the virus, the virus has mutated, yes, but in the end the host also has changed because we've built immunity. So whether we might have to reassess our treatment strategies. So I think it's an important issue that we haven't tackled at all.
Interesting. Dr. Weiss, if you see these critically ill patients from COVID-19 patients and you compare them to other patients with sepsis or septical disease based on influenza or based on bacterial infections, what are similarities and what are differences in this patient spectrum? And does this also imply that you have totally different treatment measures, or are there adaptations of sepsis patients from lessons we did learn from the COVID-19 pandemic yet?
Yeah, thank you very much for this question. And I'm still thinking about the mortality question, actually, which is linked to it. Because what you heard is that at the very beginning, when we were exposed to COVID patients, and I have to say that in Berlin, we've not been the first that have encountered these patients. I remember reading a paper from Seattle, where mortality in the intensive care unit was almost 100%. So I was asking myself, isn't it futile? Is this just a deadly disease? Can we do something? And what can we do to actually help them? And when I reflect on the treatments that we did at the very beginning, I have to say what we did is we deviated significantly from evidence-based medicine, from what we knew before. I don't know if you remember, but we intubated patients very, very early. We had these patients that had silent hypoxia, which is a distinct clinical feature of COVID-19. Patients that had no respiratory distress, but however, had a very low oxygen saturation. They were intubated at one point, but they were kept in hypoxia for quite a long time. When we intubated them, we pruned them, they got a lot of measures that we actually also in 2019 would consider not evidence-based. We administered a lot of NMDAs, for example, neuromuscular blockage, etc., etc. And it took us quite a while to get back on this track of evidence-based medicine and to say, okay, we do not tolerate severe hypoxia. We do not intubate them right away. We give them a chance on NIV. This part went a little bit to the other direction. At one point, we did non-invasive ventilation so extensively that patient actually had a lot of self-inflicted lung injury. But at the very beginning, nobody thought about sepsis actually, because the phenotype of the patient, and I think this is what you're referring to, is significantly different from what we knew. These patients were actually not, they had a fever, of course, they had a low oxygen saturation, they were coughing, but these were not patients like we usually see septic patients with a hyperdynamic cardiovascular system, you know, this kind of cardiovascular failure. We didn't see that in those patients. They were pretty stable except from the lungs that were failing. But looking at the sepsis 3 definition and just saying like it is a pathogen and it is a dysregulated host response that leads to organ failure, that is exactly what COVID actually does. But the phenotype looked a bit different. So it took us a while to realize that it is a subphenotype of sepsis that we are not exposed to that often. It's not that typical. For example, if you have a patient with a hemorrhagic flu, influenza, the patient is usually on high catecholamines. He needs a lot of fluids, etc. And you have all of these things like a bacterial sepsis. That's not the case in COVID. So that took us a while to realize that. But the most important point at the beginning of the pandemic for me was coming back to this track of evidence-based medicine and do what we actually have done before and try to avoid these severe deviations into things. I mean, we got a lot of, you know, hydroxychloroquine, you know, all of that, right? Azithromycin, whatever. Patients got a lot of, no, we didn't. But there was a lot, we were exposed to it. We did a lot of telemedicine. I've seen over 1,000 critical ill patients, and I had to convince so many people to not give hydroxychloroquine, to not give azithromycin, to not, you know, do all of these experimental treatments that had no evidence at all.
That was an interesting phase, actually. I remember that it was the threshold to try something new was relatively low. Do you think that damaged actually treatment of or patients in a significant amount, or do you think that rather actually helped because we had no choice but trying different things quickly?
I have to say that in Berlin, at the very beginning, the Berlin Senate did something very clever. They said we need a network of hospitals in the city treating primarily critically ill COVID patients. Not every hospital should do it. And they had a quite clear containment strategy in mind. And all of these hospitals that were primarily chosen to actually treat COVID patients were also equipped with telemedicine and connected to Charité, to the team of Live and us. So we were working together from the very beginning. And we stopped so many of these individualized therapies and trials at the very beginning. And we were a big team in Berlin of intensive care physicians discussing these cases from the very beginning. So you could not do what you want or what you thought was good, but there was a big peer group that was actually creating a lot of pressure to adhere to evidence-based principles. And it was good for our patients. If we look at the COVID mortality data here in Berlin, they were excellent. And we had never the situation that we had to triage patients or that we had to refuse to put a patient on a ventilator, which was completely different, for example, from the UK, where the age threshold for getting ECMO was constantly lowered. until it reached like, I think something like 40 or even 30 something. Yeah, so that was a completely different situation here. And why was it a different situation? Maybe partly because we were lucky, because we were a bit later than the rest, because we had good connections to other people, to our colleagues in New York, to our colleagues in northern Italy, in Milano, for example.
So actually a big part of this.
Exactly what Uzma said. It was so important to network and to talk to people, to listen to people, and that they said at the very beginning is you need a strong network. You need to make sure that secondary referrals from smaller hospitals to bigger hospitals with ARDS expertise and ECMO capacity, that these things are actually available. And really on the winning side at this was that the Senate at the very beginning listened very well and let us give this concept, which is called Safe Safe Berlin at COVID-19 concept. It's a very weird German acronym. So if you're interested, I can tell you, but it's a very weird. Sicherstellung, it starts with Sicherstellung, safe. And it was very successful for critically ill patients. Actually, it worked very well.
What you would like to comment?
Just a short comment, because to make clear that also bacterial sepsis have very different phenotypes. So meningitis sepsis, you may die within 12 hours. So this is completely different from a pneumonia-derived sepsis or a peritonitis. So just to make sure, sepsis needs to be looked at individually, both clinically, and also in the future we will have more biomarkers to let us know. And just from my knowledge, and that's a question to you, in influenza, so in the Spanish flu, there is evidence that 90% or 95% of these influenza patients had bacterial co-infections. So they had specimen there. But pardon? Yeah. So, pneumococcus, and that's what I learned from this, that some influenza types brown secondary influenza or foster secondary infection, which is not the case obviously with this virus.
Maybe I can very shortly comment on that, because I think we have to differentiate of a primary superinfection, which is often the case in flu patients that come severely ill, or those COVID patients that are treated on the ventilator and probably even on ECMO for 30, 40 days. They all have a ventilator-associated pneumonia, all of them. There is none that doesn't.
Of course, really curious on how the other parts of the world look at COVID-19, but also on sepsis. And Dr. Jacob, we heard from Dr. Syed about structural racism. And if you look at COVID-19, but I think particularly on sepsis, the black population has significantly worse outcomes in sepsis compared to whites or Hispanics or Asians or other populations. And I would be interested in your experience in this field, working in southeastern Africa about this, and what may be strategies to address this. Is this something that changed during COVID-19, or did COVID-19 just add on this issue? How did you perceive this?
Yeah, thanks for the question. A difficult one. I think that the disparities, as Dr. Syed has already told us, were most met or witnessed in low and middle income countries, particularly in sub-Saharan Africa. So she told, about the vaccine story, but when we look at just the fundamentals of how we care for patients with sepsis, we think about, being able to recognize them, being able to provide fluids, provide the antimicrobials, provide oxygen. It's those fundamentals even prior to COVID, where those might not, sort of varies. There's sort of different access to even the fundamental care that we might want to provide depending on where you are throughout the very large continent, whether you're at a private hospital or you're at a public hospital. So, you know, some of the things, in addition to vaccine, and we talked about treatment, one of the big areas of disparity was also oxygen, right? The availability of oxygen. And certainly in Uganda, I can speak from that. In the place where I live, I was on I was the chair of the subcommittee for the Ministry of Health to kind of build the oxygen ecosystem. And the regional referral hospitals, probably within the 10 years prior, had all put together the PSA plants for oxygen at the various sites. But there wasn't a clear understanding to what extent those oxygen plants would be able to provide oxygen to patients had there been a surge in cases. Mm-hmm. We're very lucky that in many parts of sub-Saharan Africa, there wasn't the huge surges that you witness in Europe and New York and elsewhere. But for a very long time, we were bracing for that big tsunami to hit. And one of the biggest issues was whether we were going to have oxygen. And the challenges were that, on the one hand, there was sort of a qualitative understanding of oxygen. That we've got oxygen plants and all of our regional referral hospitals were good. But it didn't correspond then to trying to calculate, when you have this capacity of a plant, that this is only going to be able to supply X number of patients. And then, you know, so that's sort of the baseline context. Now try to introduce all, you know, the varying approaches to management, you know, from hydroxychloroquine to things that did work, like high-flow nasal cannula oxygen. The appetite and the possibility of anything that might be available becomes a greater option. So the use of hydroxychloroquine was used far beyond when much of the data existed across the globe, because it was available. And there were studies that were being done, but it was often available. Things like high-flow nasal cannula oxygen, which were meant to be, you know, sort of, you're seeing your ability to save many lives with HFNO. Now you're dealing with plants that had a very limited capacity, and giving that care to one patient would minimize the care that you would be able to give to many other patients. And so it's always these research challenges that sort of inform potentially the approach that might be, that a clinician at a bedside might face with the resources that they have. And really trying to decide, you know, can you go back to the fundamentals even when those fundamentals may not exist?
Did anything change during COVID? Did it, like, in the aftermath of COVID, did you have improvements, see improvements in care also for other critically ill patients, or basically return to the same as before, or anything positive that came out, all of our experiences worldwide with the COVID-19 pandemic?
Yeah, I appreciate that question, because it's often easy to speak just very negatively and be down on things, but I think that there has also been a lot of opportunities, so thanks for the opportunity to highlight that. I do think that what this did bring was a number of people, countries, you know, governments, clinicians, and these sorts of networks saying, okay, we do need to do something about this. There is a problem about access to oxygen, to vaccines, to treatments, et cetera. And so that did result in investment of resources from the World Bank, from others, to really invest in health infrastructure. And so in Uganda, there is an increase in the availability of oxygen. There is an increase in the ambulance systems, which, you know, even though there were ambulances that ran throughout the country, it wasn't a formal ambulance system. So the Emergency Medicine Society in Uganda and around really came together and were able to really galvanize their strength in being able to respond to the outbreak. And all of that now has staying power and the ability to manage sepsis and other severely ill patients in the future.
Mm-hmm. Dr. Hunger, as a member of the Robert Koch Institute and a central role in COVID-19, in the COVID-19 pandemic, but also now, I assume, in thoughts about how to be prepared better in the future, what is your view on being prepared not only in Germany but also maybe on a European or global scale? Is that a topic that is in focus at the RKI, or how is that being discussed at your institution?
Yes, thank you for the question, and thank you for inviting us as the National Public Health Institute here. I would have to say, of course, lessons learned, processes, or better, lessons identified, learned is a different thing, is part of every post-crisis process. And of course, we are doing it both at the national level, but also at the international level. Please remember that the Robert Koch Institute did not have a Center for International Health Protection until the beginning of 2019. So traditionally, we were kind of like more nationally oriented in terms of our activities. Of course, like every good scientific research institution, we had our international contacts. You don't work scientifically without that. But since 2019, we have been looking more towards the global health scene, and we have become much more active there. It was interesting. I mean, we were established in 2019. Our boss, Johanna Hanefeld, came in 2020, and then COVID came. And like everyone said, we were building the ship as we were sailing it. And most of our first 3 years basically were spent in kind of connecting our experts with experts from across the globe in order to answer specific questions, to kind of like exchange on how crisis response could be optimized, what the experiences were, etc. And we also had, since 2016, established a series of partnerships, mostly with African countries, primarily with Nigeria, with Namibia, with Cote d'Ivoire. We had a long-standing Guinea, and then increasingly also with Madagascar. So those are kind of like our priority countries. And all of these partnerships then allowed us in 2020 to kind of work together in order to manage the COVID-19 crisis in those countries also. And in my experience, what we mostly did, of course, as a public health institute, we didn't do so much health care, although we did have a few telemedicine projects. But we did a lot around IPC, infection prevention control, of course, and vaccination recommendations, also vaccine hesitancy. So basically all the all the non-pharmaceutical and pharmaceutical countermeasures that you can imagine. Now, what we are doing now is looking forward and being very much involved with the international processes that are running, and there are a lot, like you have the pandemic agreement negotiations, you have the updates of the international health regulations. We have a much stronger network of national public health institutes now, JANFI, which is one of our favorite partners also, because they're just technically, politically, are they our ideal partners. In my view, we will see where this is going, whether we will have a pandemic agreement and we will have updated international health regulations. The two things that I think we all learned is equity. We heard that so many times already this evening, but I think how to actually manage more equity at the national level, because I think we also learned at the Robert Koch Institute, if we don't know our communities, we can't react quickly. But also at the international level, and there's a lot of movement, and I don't think we often understand how frustrated and how bad the views in the South towards the North are. We really have to take this seriously, not just for public health reasons. And the other point I think that came out very clearly, and that's my last point, is that we need to become even better with research during crises. We need this kind of like ad hoc data, not planning long studies as we did sometimes. And then when the results are out, the pandemic is already in the next phase or has moved elsewhere, or there's a different. So this kind of like very ad hoc, very quick research during crisis, I think we need to be better with that. And I think that's probably true for the clinical area, also for the clinical care area, but especially also for public health.
Particularly with studies, clinical studies and trials. We all know about these issues at Charité, how slow approvals of studies go and how slow recruitment goes. Maybe your institution could also participate in making that more efficient in the future. A related question, moving to sepsis, as we heard that this is like similar in symptoms, but it's actually more numbers, but it's it's less represented in public communication and like mindsets. Is there something that for sepsis we should, from the scientific and clinical community, take up in discussions with RKI, or is that something that is present at the RKI and the topic that is also being discussed, like aside from pure COVID-19 related issues?
Yeah, I mean, our sepsis experts, of course, know about these things. There's quite a lot of activity going on. So I don't know. I mean, I'm not a sepsis expert. I actually like the opportunity to kind of do a bit of reading up on the topic. So I mean, there's always something to discuss. That's not that's not the issue. But I would guess that we are on the same side in this, and it's more kind of like looking at how can pandemic preparedness, and I mean, we prefer the term epidemic preparedness because not every big outbreak is a pandemic. So, I mean, unfortunately, this has now become such a big word, that good clinical care and early recognition, just like for the whole outbreak, is also important for individual patient care. And yes, of course, we can probably work together to improve communication on that. But I don't think we would be the primary institution to do that.
Dr. Yashi, the risk factors, when you look at them for critically ill outcome or poor outcome in sepsis, are in some aspects quite similar to COVID-19 critically ill patients, like advanced age, immunosuppression, diabetes, overweight, hypertension, and so on, cancer. And what is your impression? Did the COVID-19 pandemic increase general awareness for sepsis already? Or can we find a strategy to use what we learned from the COVID-19 pandemic to use that now to make this other health problem more aware in the public sector and also in the networks that you use on a global scale?
Thank you very much for this critical question. And as reaffirmed by the different studies and confirmed today by colleagues, it took a while to recognize the share of sepsis burden, viral sepsis burden within the COVID-19. And as rightly mentioned by colleague, very often during the COVID-19, we were confronting the political side of the pandemic management, even starting with the basic terminology that we're currently using, to focusing on the agenda that was politically driven. And even if you look at the WHO or any other global health authority reports, you would not find sepsis in any of the official reports or in the excess deaths reports. Only through the support of our colleagues and scholars, we could identify this critical link. But we have to realize any future pandemic, because of the current context of antimicrobial resistance, because of the current burden of both infectious and non-infectious sepsis, will have a considerable connection to sepsis, and how we will effectively manage sepsis will very much define the outcomes, the clinical outcomes of the patient. So in any other future pandemics, we have to position sepsis more centrally, and also, of course, in the ongoing dialogue of antimicrobial resistance. And one last point, actually, from the policymakers, there was a question about depoliticizing the pandemic response. What we have seen was that many countries, especially countries with still fragile democratic institutions, they have managed pandemic without any major transparency or exchange of experience between the field experts. Even the Freedom House reportings that since the outbreak of the pandemic, the status of human rights and democratic institutions has worsened in 80 countries globally. And this is very much to deal with the independence of the global health authority, the World Health Organization. How WHO is managed and how it is politically and financially dependent on the member states, basically the ruling parties and the ruling ministries of health, that was one of the challenges, because we never had an independent monitoring system of how the pandemic was kind of responded and addressed at national, regional, and global levels. So that's another big question that I think we have to look at in the future pandemic preparedness.
For awareness of sepsis, is there any strategy that can be followed to increase this within the next years, using maybe some of the experiences that we had in the last couple of years?
Absolutely. When we speak about the renewed agenda for sepsis that will be released in early 2024, this will be led by the Global Sepsis Alliance in partnership with the German-based partners, Virchow Foundation, and the international partners. And definitely the strategic communication will be a central piece. We have to raise awareness among public. We have to raise awareness among policymakers as well as the clinicians. And this would be an area where we will definitely need to invest more.
Maybe I can ask a critical question to Professor Reinhart regarding this, because there are studies that show that aggressive education campaigns and early identification may actually lead to an overdiagnosis of sepsis. And with higher rates of antibiotics applications, Clostridium difficile infections, and uncertain potential for general care of this patient population. How do we balance this, and are we in some countries like Germany, USA, or areas at a point where sepsis awareness and overtreatment are already kind of balanced, or how do we proceed from such studies that are not pointing to the dilemma of sepsis, lack of sepsis awareness?
That's a very important question, because this belongs to this kind of fake news, to be honest. And there's an esteemed colleague from the Imperial College who has written a correspondence in 2019 to the Lancet, which was titled Sepsis Hysteria. And unfortunately, although he has never commented scientifically any of these high-level publications that again and again demonstrated that the burden is tremendously higher than it is. And this is because it's completely non-evidence-based and not backed by data. There was this suspicion also on serious scientists from the US, from the Boston area. There was a similar point of view in the New England Journal before by the group of Rhee. And based on this discussion that this is related to billing, etc., what the US could do, and which we could not do yet in Germany, is the CDC spent 15 or 20 million to use 40 hospitals who have electronic health records. And the result of this study was that it was assumed that in 2000, based on ICD-coded sepsis cases, the incidence was 1.5% per hospitalization. It increased until 2018, this kind of documentation, to 2.4%, whereas the electronic health record reporting ended up that the true incidence is 6%. And you may remember this slide. In Massachusetts, during the pandemic, the incidence is 8%. And when we looked in our health records with an innovation fund, we found the same thing. This underreporting of sepsis in some hospitals. There were 10 hospitals. Only 10% of cases were reported, and in others up to, and overall it was again only 1/3. So there is, and to this other question, from all studies where antimicrobials, and it's mostly a question of timing, also from the UK, the public awareness campaign after NIH had done a report which was entitled "Just Ask, Could It Be Sepsis?" This was because 40% also in UK of patients in these 20 hospitals where an independent commission looked up the timing where the first time antimicrobials was administered, it was only in 40%. In the death certificates, in 60% of cases, sepsis was not documented. In the discharge, it was not the case in 50%, and that's why they took measures. And if you go through UK, you find, and we learn from them, that at every emergency car and helicopter, you have a big poster, "Just ask, could it be sepsis?" And mortality rate in this 2-year period where NHS made sepsis a priority because Jeremy Hunt publicly apologized for the bad service of NHS in terms of that quite a number of children died. So this made a difference, and they looked up also, yes, in some hospital oxygen consumption went up, but there's not a single indication that if you use antimicrobials in these very sick patients, that then there's an increase in antimicrobial resistance or as a side effect. So that is the reality. And just to add another thing, how important is that we keep with science. This colleague was invited by a Belgian hospital on the occasion that a sepsis survivor who was not accepting that she lost 2 legs due to unrecognized hospital. We had them on our World Sepsis Congress here, and she achieved to make a public awareness campaign, and to counteract this, she sent me, because she had read this quote by this, I don't want to say the name, colleague. Who is he? Because he was from the Imperial College, because she feared that the media would take up this argument just to apologize and not to need to integrate or to adopt where the evidence is unique. It's a tons of data that indicate that if you increase awareness, you can be as low as 9% or 10% with your sepsis mandatory. And if, of course, there may be some patients who get for 1 or 2 days antimicrobials, and if you withdraw them and replace them either by another, or if it's just viral, then so there is no indication that in this case lack of awareness kills.
Maybe Dr. Jacob, it would be a very interesting question if the issues that we're discussing here regarding sepsis awareness in Europe are similar to the issues that you are having with this disease in underserved areas, particularly Africa. Is it there also lack of awareness, or is it more lack of resources for treatment, or is it a combination of both? Or what would you think are similarities and differences if you look at a first world and a third world country in treatment of such critically ill patients?
Yeah, it's probably a combination of both parts. I think, you know, there have been a few surveys that have been done across the continent trying to understand various stakeholders' awareness of sepsis. And yeah, I mean, sepsis is often just associated with neonates or peripartum mothers, so not recognized in adults and non-pregnant adults. And people associated with wounds, but not necessarily, sort of other common manifestations of sepsis. So a general recognition from all, we've done some studies in Gabon and Malawi, sort of interacting with key stakeholders at the Ministry of Health and other entities where there was a very heterogeneous understanding of what sepsis is. And so even at the policymaker level, if you're already sort of having a heterogeneous understanding, there's not going to be a systematic approach. But I think to counter that, where's the solution? I mean, this has been touched upon already, but sepsis is such an important condition because it's sort of an indicator illness for your health system. If your health system is able to manage sepsis really well, then you have addressed issues around triage, you've addressed issues around early recognition, you've addressed issues around early treatment, whether that's for sepsis, whether that's for other emergencies, whether that's in the context of an epidemic or a pandemic. All of these sort of going from early recognition, even in communities, at the front door of the health facility, monitoring in the wards. If you can get sepsis right, you can get many other things right. And so there's a huge opportunity. I think, sure, there are resources that are constrained, and there's a lot, further along that we need to get to be able to provide, sort of the optimized care. But this sort of level of recognition, the triage and the initial care and monitoring could really do a huge amount. And it's just that simple shift in thinking by saying, okay, sepsis is, if we put this through our health system and we improve that, what are the knock-on effects for any of these other conditions?
Well, we are approaching the end of the discussion round. If you agree, I would like to ask each of you for a closing statement, either on COVID-19, what we learned from the pandemic, or on sepsis, what are the next steps to do? And would you like to start?
Just spoke, probably said what I was going to say. Yes. Yeah, I think there's a lot. So I'll speak on sepsis from the context of sub-Saharan Africa, where I'm working, and where sort of all my colleagues are working. I think there's a huge opportunity. It really is that mortality is high. We know that it's upwards of 45 to 50% in adults, out to 28 days from their presentation. And othentimes these are patients in their 30s or 40s with HIV immune suppression. So these are people who otherwise healthy would be contributing, sort of have a lot of contributions to their communities. So this is an opportunity and really a clarion call to get us to think about sepsis for the reasons that I already mentioned. That could really change the outcomes on the continent. So that's mine.
Well, I think a lot of important issues have been touched upon, and I'm not going to comment on sepsis awareness. I think there's other people here on the panel that are more qualified to speak to that. But I want to sort of recur to some of the points that we've heard before. I think one of the issues, I mean, at least, and that's probably true for low and high and middle income countries, is that even if we have good, widely available, cheap treatments available or vaccines available, the fact that, disinformation has been spread and has been propagated even by, media outlets and parts of the political spectrum and are still being propagated. What are you going to do on a healthcare provider level, on a science level when you run studies? The pharmaceutical industries producing that, and governmental bodies buying millions of doses of vaccines when uptake is down just because of the spread of false and disinformation, spread of fear, and sort of using that anti-scientific agenda, political agenda against, a very legitimate public health goal. So I think that's what we're seeing in our country. We're seeing it to the extreme in other countries. I think in the United States, it's very good where you can see basically along party lines, vaccine uptake going up and down. So I think that's something that we've learned. It's a hard lesson that we've learned from this pandemic, that all the things that we need to do better in terms of science, in terms of better care, early recognition, all of that is basically not useless, but is basically minimized if we don't tackle that problem of gaining trust, bringing clear, transparent information out to the people in a way that sort of makes it clear what we know and what we don't know. And in this sense, basically can contribute to better understanding and literacy in the population of what is needed and what might not be needed, and also that things can change over the course of outbreaks, and so yeah, that would be my take on the lesson that I think learned through this pandemic.
Dr. Weiss.
Yes, difficult to make a final statement on that, but I tell you a story. We had a 27-year-old woman that came to our ICU. She was pregnant in her 3rd trimester. She contracted COVID. She got critically ill, and we knew we had to deliver the baby. There were 22 people in the room, 15 of the most qualified physicians you can think of. She got an emergency C-section. She was put on ECMO, on mechanical ventilation, and she survived. She came to our post-intensive care syndrome outpatient service and to the ICU rehab. I saw her, she's happy. And child is well, everything is well. And like 1-2 days later, cynically, I did a teleconsult in Uzbekistan, in Tashkent. And we had a 20-something-year-old, I can't say if she was also 27, but she was close to that age, a pregnant woman on NIV, on non-invasive ventilation, deteriorating, and I talked to the doctors, and I knew from my experience just a couple of days before what could actually help her, but they simply didn't have the resources. The woman and the baby died, both. And that happened 100 times. And I thought 100 times, what can we do for these poor patients, because they are also my patients. I also do teleconsults with them, and I consider them my patients as well. And I only came to the conclusion that it is extremely important to have public health measures and to prevent that those women get infected in such an overproportional high rate. And this is where really the target, especially in these populations, lies at the moment, because I cannot bring an ECMO and this kind of Northern Hemisphere medicine to them. However, so I wish that there is more awareness. I wish that there is resources in the very proximal part of the disease, that we try to make containment and preventive measures as accessible and easy as possible, and of course to increase equity. But these stories have been very challenging to see, and to see the contrast between an ICU at Campus Charité Virchow and an ICU in Uzbekistan, for example.
Can we go on with Professor Reinhart and then move back to you, so we have you as a closing remark? That would be nice.
Yeah, I want just to reiterate that lack of awareness kills, and this is even true in high-income countries, as I have shown you the data with the mortality rate for sepsis in Sweden and in Australia half as high, and if you add quality improvement, education, you can get even lower. And it's hard to accept that we live in a country where our expenses for the healthcare system is 40% over the European average, and our quality, measured not only in sepsis, because sepsis is even not in this OECD report. We live in terms of avoidable deaths at rank 17 to 18 between Greece and Slovenia. And just to make this point that the quality of the healthcare system matters, it's also true for myocardial infarction. Although there's no country in the world who has more ICU beds, more health catheterization places. There are 3 countries where it's higher than 8%. This is Slovenia, which is in Germany. This is Iceland, Lithuania, and Letland. But there are 5 countries in Europe where it's 4% and lower. So this has to do, we can't, this is not a case of awareness. That's why we support also a Sepsis Foundation, this hospital reform, that only hospitals do that where they have the expertise, 24/7 expertise on a high quality Facharzt level, which is defined by law, that every patient in Germany has this. And as long as we don't have this healthcare reform, and as long as also our policymakers and decision makers don't understand that the similarities between COVID consequences and sepsis consequences, which is just the case because they have just launched a program for COVID survivors so that their symptoms, which are almost the same, are respected and recognized, as long we have a problem, a knowledge problem, and not, and of course, okay, I stop here just to make this, so this point, and yeah, stop.
Dr. Hunger.
Yes, just 2 points quickly. The first is, I hope that we really keep in mind what we know now and not forget it, and also keep the things that we developed. And that can be as easy as a better mortality surveillance in Germany, or the DV intensive registry. I don't know what you think about that. I would be interested. It actually seemed to help to kind of channel patients. It also means that we keep the raised political attention on the need for good public health and good health care, because that's a precondition for a good society, basically. And the last example that I want to make is that we remember that we need better evidence for the non-pharmaceutical measures. I think we really need to kind of catch up with science there, or the science. Yeah, we need better studies on that. And my second point would be that we keep in mind that strengthening local level public health and maybe even local level health care, or at least kind of access to health care, so that we actually reach everyone in our society, especially those who are kind of like further away from the system, especially in terms of early recognition, being at the doctors early enough to actually be able to help.
Thank you. Dr. Yashi.
I'll try to keep it short. Therefore, I will focus on the sepsis agenda, if you may let me. Definitely, the pandemic has brought lessons, shocks, suffering, but also the hope, the new knowledge exchange, and opportunities. So I would really wish for us as, to use this opportunity of strengthening the global response to sepsis, because we truly have a historic opportunity, as Chef noted, of making one major success story in global health. And we're not only talking about professional challenges or ego-driven successes, but behind that story is the life of 11 million children, women, and men. We have the historic opportunity of saving every year up to 10 million lives. And we couldn't ask for a better cause as the clinicians or global health experts. And being based in Berlin as the Global Sepsis Alliance, thanks to the foundational work of Professor Reinhart, Germany has a unique opportunity to become the leader in the global sepsis response. Due to the history, legacy, and expertise of Charité, definitely, due to the World Health Summit, due to the Virchow Foundation, the first global health subcommittee of the German Parliament, Bundestag, engagement of the 5 members of German Parliament in the sepsis response. And if we work together, first of all, we would be honored and delighted, but we can really make a success story that Germany can be recognized as the game changer. So that would be my closing remark. Thank you.
So I can't really add anything to this. So I would like to thank all of you and the speakers for this very insightful and interesting afternoon, evening, with 2 views on sepsis and on COVID-19 that are intertwined. And I think we saw a lot of data and got a lot of new ideas on where this will develop. I want to thank this audience, of course, for participating, and also the audience that was here online, and now in the aftermath we have some time for further discussion downstairs at the, I think it's a buffet. I'm not sure what we will have, but at least some get together. Thank you very much.